Welcome, welcome, welcome in, everyone. Welcome to Care Concierge with Care Patrol, where education is the heart of everything we do. We appreciate you being here. I hope you all had a wonderful holiday Thanksgiving weekend and that you are ready to be back at work and face a new week of challenges and opportunities. Our topic today for those of you who are joining us is the one that has been requested several times by prior attendees of other sessions. We ask in our evaluation for topics that would be important to you. And we list those topics every Monday or most every Monday at noon via Zoom. And good morning and good afternoon and greetings to all of you on the chat, and thank you for participating. As some of you know, we are Care Patrol. Care Patrol is an aging care navigation service, which simply means that we meet people in their journey, in their healthcare journey, whether they're in a planning stage or in a crisis stage, in an ER or hospital room or rehab or other community, and understand what's next, or help them understand what's next in their journey, how that's paid for, how to qualify and engage those services. And we do all that at no charge. We're paid by the providers in our network. Those providers that accept private pay, not Medicare money, can pay a referral fee to us when we bring them a qualified potential patient or resident. And that's how we work. So everything that we do, including our education to our families, as well as our education for you, is at no charge. Discussion is encouraged. And we do look for you to add to the discussion, because I will say this is a difficult topic, and I think we will all be enhanced by any observations or outcomes that you might report given the topic. We do encourage discussion. If you're not familiar with the chat room, move your cursor up to the top of your screen or down to the bottom. You'll see the word chat. Click on that and join us, please. We use a password protected evaluation. And we do this because the Alabama Board of Social Work, that accredits this hour for 1.0 contact unit hours, says that if we use this password protected online evaluation, this will be considered a live or classroom session for those of you who are social workers. We're also approved by the Alabama Board of Nursing. And nurses on the line, we will be posting your hour to the ABN website on your behalf. Everyone who does an evaluation will receive credit for this hour and this presentation for your use. But you must do the evaluation to get credit. Those who've been with us before know that I'm attentive to the fact that some of you are not able to see the screen. So I will read to you now the evaluation link for you to make note of it. We'll read it again at the end. And again, this evaluation is password protected, and we give the password at the end today so that you can log in and complete the evaluation. The login link is https://www.surveymonkey.com/r/ all uppercase letters, V as in Victory, F as in Frank, D as in Dog, Z as in Zoo, H, R, C as in Cat. That's our evaluation link for today. Please remember it's password protected, and we give the password out at the end of today. Let's move right into our objectives for this session on suicide prevention. One, we're going to discuss the magnitude of the problem of suicide in the United States and allow you to have that knowledge from this presentation. We're also going to, in Objective 2 for today, discuss how we might assess someone who is at risk or for risk of suicide and the various risk stages. And then Objective 3, we're going to list some prevention strategies for you to share and use in your practice with your patients and possibly even others in your lives. So those are our objectives today. And I just want to say that this is a very difficult topic, suicide. And if this in any way triggers you today, I want you to be aware of the suicide hotline, which is 1-800-273-TALK. And TALK is simply 8255, 1-800-273-8255. Or you might also visit suicidepreventionlifeline.org. But please, if you are triggered in any way by this conversation, do provide yourself with self-care and to plan and reach out to someone. Oh, 988. The number is now just 988. Well, thank you, Ms. Claiborne and Ms. Burks. Easy peasy, 988. You're so right. I have been struggling with trying to remember myself in giving this presentation, 1-800-273-TALK. So 988 is much more approachable. And thank you all for correcting me in front of the audience and letting them know the correct information. I depend on you for that, and I appreciate you doing so. In 2012, the federal government put into place the National Strategy for Suicide Prevention. And there was a group formed to create this strategy called the Action Alliance Task Force on Survivors of Suicide. And I thought it was fitting as I read through the information for today and did a little research. I found the preface to the National Strategy for Suicide Prevention, and it reads, "To those who have lost their lives by suicide, to those who struggle with thoughts of suicide, to those who've made an attempt on their lives, to those caring for someone who struggles, to those left behind after a death by suicide, to those in recovery, and to all those who work tirelessly to prevent suicide and suicide attempts in our nation, we can and will make a difference." And that is my pledge and charge to you today. The leader of the task force in 2012 was the former U.S. Surgeon General Regina Benjamin. And in the preface for the national strategy, Dr. Benjamin stated, "Reducing the number of suicides requires the engagement and commitment of people in many sectors in and outside of government, including public health, mental health, health care, the armed forces, business, entertainment, media, and education." And Dr. Benjamin further suggested that 1, suicide is preventable. 2, suicide prevention requires a public health approach combining clinical and community-based approaches. And 3, everyone has a role to play in suicide prevention. So I'll ask you to continue our discussion for today. How pervasive a problem is suicide? Do you know someone who has been affected by suicide, or God forbid, have you? How pervasive a problem is suicide? Do you know someone? Oh, Lynn Bass lets us know that Dr. Benjamin is from Alabama. Well, that's another great reason to be from this state, isn't it? How proud I am to know that. Our state is really home to a lot of people who excel on the world stage. Dr. Benjamin is just one. And I expect that some of you excel in what you do. Perhaps it's not on a world stage, but you excel in your clinic or place of work, and we appreciate it. Well, excuse me. There's no group in our society is immune from suicide. The factors that contribute to suicide deaths are preventable, but they are also multiple and complex. Suicide touches many of us in the United States. Many of us know someone who has attempted or died from suicide. And perhaps someone on the line has considered or attempted suicide yourself. Some are affected in a more remote way through someone in a work group or school or a community involvement in which they've committed suicide, and it affects us greatly. In fact, between 2001 and 2009, which is the period studied for the national strategy, there were an average 33,000 suicide deaths each year. And suicide was among the top 5 causes of death for adults under age 45. In 2009, more Americans died from suicide than from traffic-related injuries. And the largest number of suicidal deaths occurs each year among middle-aged men and women, so those adults over 45. And suicide in our armed forces is a national concern. As we said, reducing suicide deaths requires the engagement and commitment of all of us, and it requires our collective wisdom, experience, and input from researchers, scientists, clinicians, and health experts. Thank you so much for being here today, as well as those who've been affected by suicide, who are survivors of a suicide attempt. The issue with suicide prevention is that it is a topic that's often met with silence and shame. And we have some comments. Keldon Jones says suicide is very prevalent in the young, elderly, veterans, and in all groups, really. Michelle Nee says, see the terrible effects of suicidal ideations on a regular basis in my hospital. Michelle, that's tragic. I hope you have a self-care program to dealing with that. And Madison Aaron says, I definitely think suicidal ideation is much more pervasive than we even realize because of the stigma attached to it. And I think that's exactly the point I'm making now. Do you know from 1999 to 2016, deaths by suicide in the United States increased 30%. In fact, it's one person every 15 minutes dies of suicide. 4 people in the context of this continuing education hour will have successfully committed suicide. Most of them have an identifiable mental illness, and about half received a mental health diagnosis within the year prior to dying. However, please note that the vast majority of people who have mental disorders or diseases do not engage in suicide. And in 2009, again, from the report, about half of the suicides in the US were from the use of firearms, followed by suffocation and drug overdoses. In 2001 to 20, the method-specific rates for firearms jumped from 24% to 45%, and suffocation nearly doubled as well to 44%. However, rates involving poisoning, including overdose, increased 22%. Hanging deaths have also increased, given that celebrities have used this means. There are many reasons, as we've stated, and not just mental illness. There may be unemployment issues that drive someone to finally commit this act. They may suffer from chronic pain or disease. They may have insomnia. They may be in the midst of relationship strain, a parting of ways, a divorce. Homelessness is a predictor of suicide, and grief is also, and these again lie outside of mental health issues or mental health diseases or disorders, rather. In 2020, the 10 leading causes of death accounted for 74% of all deaths in the US. And even though suicide rose 30%, it dropped from the top 10 causes of deaths of adults. Almost all among all US adults, including veterans, the average suicides a day rose from 81 in 2001 to 121 in 2020, the highest being in 2018. Now, I wonder, do you suppose that suicides may have dropped from the list of top 10 because a new entrant in COVID preceded them and dropped suicide from the list? I think that may be true. Over 8 million adults report having serious thoughts of suicide in the past year. 2.5 million have reported making a suicide plan in the past year, and 1.1 million attempted suicide. Almost 16% of students in grades 9 through 12 have seriously considered suicide, and 8% report having attempted suicide one or more times in the previous year. And the CDC has estimated that cluster suicides may account for 1% to 5% of suicides among adolescents and young adults. And as I stated earlier, one of the triggers for suicide is the death of someone that we know, someone close to us, a schoolmate. And suicides, as someone reported, are often underreported, so it's difficult to determine the intent for the suicide. And existing data collection also fails to capture other data, such as suicide behaviors among other particular groups. For example, death certificates do not indicate sexual or gender orientation. So rates of death in the LGBTQ community are simply unknown. We know that women are more likely than men to have thoughts about suicide and to attempt suicide, and yet men are more likely to die by suicide. Ms. Parker says, yes, my ex-coworker committed suicide and it was tragic to our agency. I'm so sorry, Ms. Parker. Thank you for sharing that. I know that was difficult. And Ms. Ball says, data collection for suicide during COVID was very challenging because most agencies were counting for COVID deaths. That's so interesting. Thank you for pointing that out. I felt that I might be on the right track, Ms. Ball. So individuals treated for alcohol abuse or dependence have a 10 times greater risk for eventually dying by suicide. The 2009 rate of suicide among older white men was 30.15 people, 30 people, or 31, if you round up, per 100,000, almost 3 times the general rate at 12 per 100,000. And yet suicide rates among African women aged 20 to 59 are 2.77, or 3 persons per 100,000. This is the lowest rate among adults. The unadjusted suicide rate for veterans was 23.3 per 100,000 in 2001 and 31.7 per 100,000 in 2020. So look at those numbers. Suicide rates among veterans equal the highest suicide rate among anyone else in the population, the general population, which is older white men. For non-veteran U.S. adults, the suicide rate is roughly half that at 16 per 100,000. And among veterans in 2020, suicide was the 13th leading cause of death. We now say died by suicide instead of committed. Thank you, Ms. Burks. I swear y'all are keeping me on point today. And I do appreciate it. This is a difficult topic for me. And I know that when you point things out, you do it with love and you do it for the betterment of every one of us. Thank you for that. Among veterans who died of suicide, the prevalence of depression was 35%, and anxiety diagnosis prevalence 25%. PTSD behind that at 24%, and alcohol and cannabis use disorders make up the bulk of the rest of the percentages. Thank you, Ms. Burks. So what are the risks for suicide? We've sort of danced around these. We know that age is a factor with certain demographics. We know that veterans have a higher prevalence of suicide. We know that mental health disorders and alcohol and cannabis use disorders can lead to suicide. What are the risks for suicide? Well, some warning signs to be aware of are clearly talking about wanting to die or looking for a way to kill oneself. But someone who approaches you and talks about feeling hopeless or having no purpose, someone who says they feel trapped or they're in unbearable pain and cannot escape, they talk about being a burden to others. If you note in conversation that they have made note of increasing their use of alcohol or drugs or sleeping more or less, eating more or less, acting somehow in other ways that are reckless, withdrawing and feeling isolated, as Ms. Claiborne pointed out, and showing rage. If you have a patient or client who is filled with rage and talks about revenge, this is someone for whom you should do an assessment. And it's obviously clear that the more of these signs that someone shows, the greater the risk that they might commit suicide. But the suicide rates are only part of the picture. As someone pointed out earlier, many people think about suicide and may engage in suicidal behavior, such as forming a plan. During 2008 and 2009, about 8.3 million US adults 18 and over, which is almost 4% of our population, reported suicidal thoughts in the past year. In a 2011 youth risk survey, 1 in 7 high school students seriously considered attempting suicide in the prior 12 months. In addition, as we stated earlier, half, 8%, were completed and died by suicide. Research has helped clarify the link between early childhood adverse events and suicide later in life, and I would suggest that suicidal ideation among youth certainly has something to do with this. And then, as Mr. Jones, or Keldon Jones, pointed out, exposure to a suicide attempt or death, particularly of someone close, can have harmful effects on families and on individuals, thus increasing the risk for suicide among them, among those exposed. And again, although there are risk factors that are long-term, there are stressful events such as relationship problems, financial difficulties, public humiliation could provide impetus. There was a politician in Alabama recently who died by suicide because of a public humiliation. Ms. Ball says social media and social bullying, glorification of suicide via TikTok are serious contributors to teenage suicide. Hear, hear. And then there are diseases and chronic pain, cancer and chronic diseases. Cancer may be the most common physical illness associated with elevated suicide risk. Those with Huntington disease, which we've discussed on 2 or 3 occasions in this series, have a 2 to 4 times greater risk for suicide than those without. It occurs more frequently in those with spinal cord injury than in the general population. And we know that almost 5% of patients who are diagnosed as schizophrenic will die by suicide. And research also indicates that engaging of acts in self-injury may lead to suicide later in life. This is true both in cases when the self-injury involves the intent to die, as well as in cases where there is no suicidal intent. And as someone with some experience with this, I can tell you that the risk is not wanting to die, it's cutting too deep in an effort to relieve the pain. Death by suicide in period after discharge from an inpatient psychiatric unit is more frequent than any other time. In fact, a study of individuals in New Zealand who survived a suicide attempt, almost half made another attempt or died by suicide within 5 years. In the United Kingdom, people who died from suicide within 30 days of discharge from a psychiatric unit before even the appointment for follow-up was scheduled or attended. Almost 400, over 400 suicides occur each year in local jails. It's not prison, this is jail. This is 3 times the general population, on the same order as middle-aged adult men, white men, and veterans. And it is the 3rd leading cause of death in prisons. This is a chart that I pulled from the DOD, and I would thank one of our colleagues who gave me the link. But if you're looking for prior suicide attempts, preparatory behaviors, past or present suicidal intent, current psychiatric conditions, these are all the things you're looking for when you are with your patients and clients. Mood disorders, anxiety disorders, psychotic disorders, personality disorders, substance use disorders, eating disorders, and history, note this, history of psychiatric hospitalization. The psychiatric symptoms that are to be considered are sense of hopelessness, depressed mood, anxiety or panic, insomnia, problem-solving difficulties, agitation, anger, rumination, impulsivity, intoxication while in the clinic, decreased psychosocial functioning or hallucinations. And recent psychosocial stressors, again, might be loss of relationship, breakup, divorce, death, loss of a job, risk of losing stable housing, becoming homeless, exposure to suicide, traumatic exposure, as someone pointed out, bullying, physical assault, emotional abuse, financial problems, transition of care. And again, this is upon discharge from an inpatient unit or a change in medication in an inpatient unit or a change of therapists such that an appointment is stalled. And these are, among others, including cost, barriers to accessing care. There are the availability of lethal means, firearms being number one, and other lethal means and access. There are physical health conditions, those who have traumatic brain injury, with moderate to severe traumatic brain injury are greater risk to prevent suicide than those who simply had mild concussions, and the cancer diagnosis, as we pointed earlier. So this is sort of a rehash, but it's in chart form, and I include it for you because you'll receive this presentation at the close of the day, and also the demographic factors that go unreported about LGBTQ patients, among other demographics that are not able to be tracked. Questions that you might ask or that you would ask in an assessment would be, for example, over the past 2 weeks, how often have you been bothered by thoughts that you would be better off dead or of hurting yourself in some way? And the possible responses then would be not at all, several days, more than half the days, or nearly every day. Now, you ask this question, if the response is several days, that person is showing a 75% increased risk for suicide. More than half the days, 115% increased risk for suicide. Nearly every day, at 185%, nearly 2 times the risk in an increased risk for someone thinking about suicide in every day. However, 70% of deaths by suicide during the period of the study when these questions were asked were among those who said not at all. So 70% of those who committed suicide during this study had said that over the past 2 weeks, they had not been bothered by thoughts of suicide. That's sobering. Why might certain groups be less likely to commit suicide, such as Black women aged 20 to 59? Why might certain groups be less likely to commit suicide, such as Black women aged 20 to 59? Please share in the chat room. And thank you all. Today has been really engaging, and I appreciate your comments. Well, protective factors for suicide prevention are not the opposite or the lack of risk factors. Instead, they are conditions. And these conditions promote strength and resilience in the client and ensure that the vulnerable individual is supported and connected during a difficult time. Religious beliefs, yes, yes, yes. There are 4 levels of influence that were identified by the national strategy. And these are on the individual level, someone's coping and problem-solving skills can play a great part in helping to prevent them from committing suicide and having reasons for living, such as children in the home, or someone who you care for, or a religious belief, moral objection to suicide. And Ms. Williams, you hit both of those. Then there are relationships, the one's connectedness to others, to family, to community, to other institutions, and the supportive relationships with you, their healthcare providers. This, I want to underscore, having a supportive relationship with you as a healthcare provider can have a serious positive effect on preventing suicide. There are community resources such as safe schools and other community environments. And there is the need for us in the United States on a community and societal level to remove the restrictions and the stigma around mental health care and also remove the restrictions on lethal means of suicide. This is according to the national strategy. So faith is the answer, at least in part, or reasons for living is the answer to our question earlier. There are 2 online resources that I want to share with you now. And so I'm just going to read them to you, but they'll be in this presentation. One is the National Registry of Evidence-Based Programs and Practices, or the NREPP, which is a searchable online registry maintained by Substance Abuse and Mental Health Services Administration, or SAMHSA. And this provides information on over 220 interventions supporting mental health promotion, substance abuse prevention, and mental health and substance abuse treatment. And remember that mental health diagnoses and substance abuse diagnoses can count for almost 70% of suicides. The Best Practices Registry, or BPR, focuses specifically on suicide prevention programs. It's maintained by the National Suicide Prevention Resource Center and is funded by SAMHSA, and the links to both are here in this presentation for your use. Now, in addition to innovative and grassroots support groups, of which you may be familiar with some in your own community, whichever community you come from to us today, but there are also national organizations for suicide prevention and for survivors, such as the American Foundation for Suicide Prevention. The link is here for you. The Suicide Awareness Voices of Education, which is a website which is really sort of populated by those who are survivors of suicide and those who are left behind when suicide is the cause of death. And then there's the American Association of Suicidology, which is also very heavily focused on loss and prevention of suicide. These, as well as community grassroots and other sites that we'll list for you later, have a significant effect, and certainly on your knowledge of how to address this topic, but also on supporting those who are in risk and in crisis. We talked earlier about a study in the United Kingdom. Here's another lesson from the United Kingdom. Suicide prevention recommendations like those in the 2012 national strategy were put into place in England and Wales over a period from about 2000 or 1998 to 2007. And a 2012 study examined the changes in suicide rates when the public sector mental health services began to implement the following 9 recommendations. One was providing 24-hour crisis teams, such as the 988 number. 2 is removing ligature points. These are materials that can be used for suicide. Firearms would have been less of a ligature point in this study because of the lack of availability of firearms in the UK. Conducting follow-up with patients within 7 days of discharge, not 30. Conducting assertive community outreach. Providing regular training to frontline clinical staff on the management of suicide risk, which I hope is something that you're accomplishing with me today. Managing patients with co-occurring disorders, mental and substance abuse, responding to patients who are not complying with treatment for the above, sharing information with criminal justice agencies, and conducting reviews and sharing information regarding those reviews with families after a suicide to support the family. Now, I wonder how many of you are comfortable with or would be comfortable with sharing information with criminal justice agencies. Is that something that's specific to that culture, or is it something that you would feel is a necessity and ethically that you are bound to do so here? The study concluded that each year from 2000 or from 1998 to 2006, as these mental health services began to implement the following recommendations, suicide rates decreased, and they decreased every year and decreased with the addition of each new bullet point. But the largest effect of all of the above was the 24-hour crisis care. Again, I would say to you, 988 is the number. If you're being triggered by this conversation, or if you have someone that you feel is at risk, please share this information with them. Wales has about the same population as Alabama does. So how might we adapt and adopt these same interventions in our state? Wales has about the same population as Alabama does, about 4 million people. How might we in the US and in Alabama adapt and adopt the interventions named above? Well, beginning, I think healthcare clinicians, you can screen for mental health needs, including suicidal thoughts and behaviors, and make referrals to treatment and community resources. And you can, in doing this, increase our capacity to deliver suicide prevention services. And when we're doing so, we want to do so in a culturally appropriate way, hence my question earlier. Settings that can be, that provide care to patients with suicide risk must be non-judgmental and psychologically safe places in which someone can receive services. Patients who have thoughts of suicide are most likely embarrassed, or they feel guilty, or they feel shameful, and they're fearful of disclosing these thoughts to anyone. And they may also fear losing their autonomy or ability to make their own treatment decisions by divulging these things. So we must approach it very gingerly. So we must address these barriers to treatment. We must be collaborative with clients so that we can get information from them. And we must not be coercive in our approach. So we have to approach this more as a conversation and less as an interview. And we must have the skills required to promote disclosure in doing this. So know that individuals who are contacting a potential helper must feel comfortable to disclose their desire or intent to die and thoughts of suicide, and they must feel confident that you, the potential caregiver, will be accepting and in a position to offer non-judgmental help. And remember that they have anxiety, as do you. So don't let your anxiety be a barrier to you in identifying a suicide risk in them. And then as we look further, strategies for monitoring patients and identifying those at risk are also needed, and these should be more frequent. We should more frequently be asking these questions and more focused on those people we know have risk factors, such as mental or substance use disorders, chronic pain, disability. We should be more intensive in monitoring those who are identified as being at high risk for suicidal behaviors, and clinical care for high-risk individuals should recognize and support recovery and be based on an understanding that these individuals will remain at risk for some time after treatment, for extended periods of time. Regularly scheduled monitoring should be implemented and should focus on evaluating changes in symptoms of medical and mental health conditions, protective factors such as social networks, the occurrence and impact of any stressful events in their lives, and the recurrence. Ask about the recurrence of suicidal ideation, plans, or intent. And we need to also lean on a support network of significant others to the individual identified as being at risk for suicide. This is a very important part of suicide prevention. And we should be training these support network members, family members, loved ones, individuals to understand, monitor, and intervene when necessary when the risk presents itself. This is difficult because the exact timing of suicidal behaviors are difficult to predict. But the network should be knowledgeable about the risk factors that may lead to suicide, how to protect an individual from suicide, 988, and when to contact treatment providers or when to contact emergency services, and how to take reasonable precautions to reduce access to lethal means. And family members need to be able to feel that they can ask directly about suicidal thoughts, but they should not be given the task of being on suicide watch. That is not appropriate and not effective. Involving the patients and family, close friends is important and underutilized. In fact, if you think of this, think of it in the same sense that you would think of someone recovering from a substance use disorder who would be attending a group therapy session, an AA meeting or NA meeting, a 12-step program in which there's a built-in sort of element of peer support. That same element of peer support can be built in and around that person at risk for suicide. The World Health Organization brief intervention and contact treatment modality for suicide prevention states that a 1-hour individual information session should be planned as close as time to discharge as possible. And this is with the individual and the family. And after discharge, there should be 9 follow-up contacts, phone calls, or visits as appropriate, according to this specific timeline over the course of 18 months, at least at 1, 2, 4, 7, and 11 weeks, and at 4, 6, 12, and 18 months. So this is the level of follow-up required. And this should be conducted by a clinician, by someone with clinical experience, such as each of you on the line. This protocol was found to significantly decrease suicides among patients with histories of suicide attempts in China, Iran, India, Brazil, and Sri Lanka. And what we found is that the buddy or peer-levered post-discharge support was effective. Case management and care facilitation was effective. Telehealth monitoring, when important or when possible or necessary, was put in place to achieve these contacts. and interventions, including dose response to medications or changes following the ED or psychiatric hospitalization were put into place. And these are strategies that can be effectively implemented in the US. While we might culturally adapt to those, for example, we might use text in the United States as a way to contact someone, and that would be perfectly appropriate. What would matter would be the contact. Excuse me. What tools can be used to perform a suicide assessment? What tools can be used to perform a suicide assessment? Well, the most prominent one that I've found is the ASK tool. It's the Ask Suicide Screening Questions. And those questions, similar to those in the study we looked at earlier, are rather, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off? In the past few weeks, have you been having thoughts about killing yourself? Have you ever tried? And are you having thoughts right now? This is something that you can pull from the internet and use it if it's something you'd like to implement in your own ability to assess. Another thing you might find that I think is interesting as well is the Columbia University Suicide Assessment Tool, which asks those questions in a little different way and ask about the past month. Have you wished you were dead or wish you could go to sleep and not wake up in the past month? And then always asking the last question on this page, which is, have you done anything, started to do anything, or prepared to do anything to end your life? So if someone screens positive on the ask, this is a prompt. And what you do is, one, praise the patient for discussing these thoughts. And then follow with, I'm here to follow up on your responses to the suicide risk screening questions. These can be hard things to talk about. Thank you for telling us, for telling me. I need to ask you a few more questions. And then you do the assessment of the patient. You review the patient's responses. You interview the patient alone during this time, and you try and determine the frequency of suicidal thoughts. You would ask, in the past few weeks, have you been thinking about killing yourself? You would ask, if yes, how often? Do you think about this once or twice a day, several times a day, a couple of times a week? And when was the last time you had these thoughts? And are you having thoughts of killing yourself right now? If yes, you do not leave the patient alone, and you do reach out and contact the appropriate authority or ER or whatever you deem appropriate. You're assessing and doing all this if the patient has a suicide plan, regardless of how they respond to any of the questions. You want to ask about method and you want to ask about access. So you ask, do you have a plan? If you do, would you please describe it? And if you don't, how would you? If you don't have a plan to kill yourself, but you think you were thinking about it, what might you do? Now, here's when you know that if the patient has a very detailed plan, that's more concerning than if they don't have a plan. But remember, according to the study we looked at earlier, that 70% of the people who you approach may say no to these questions. They may say, no, I've not thought about this in the past 2 weeks or month. You also want to look at the past behavior of your client and ask if they've ever been someone who self-injured or has tried suicide in the past. And if they did, how did they do so? And when and why did they do so? Have you ever tried to hurt yourself? Have you ever tried to kill yourself? Did you want to die? Did you think that doing what you did was going to kill you? Did you receive treatment? Past suicidal behavior is the strongest risk factor for future attempts. And you might again ask this series of questions. If you're trying to determine depression, have you felt so sad or depressed that it makes it hard to do things? Have you felt so worried that it makes it hard to do things? Do you often act without thinking? In the past few weeks, have you felt hopeless, as if things would never get better? Have you felt you couldn't enjoy things that usually make you happy? This is called anhedonia, when you can't find pleasure from things that usually give you pleasure. Are you isolating? Have you been keeping to yourself more lately than usual? Irritability. Have you been feeling grouchier lately than usual? In the past few weeks, have you used more alcohol or drugs than you usually do? And if so, what do you use and how much? And has this caused any other issues or problems in your life? In the past few weeks, are you falling asleep or finding trouble falling asleep? Or are you waking up in the middle of the night or earlier than usual in the morning? Have you noticed changes in your appetite? You've been less hungry or more hungry? And recently, have you had any other concerning changes in how you are thinking or feeling, or changes in your mood that we haven't discussed? And then for all the questions we'll go below, ask patients to describe answers that are yes answers. So is there a trusted person you can talk to? Who? Have you ever seen a therapist or counselor? Would you? When and for what purpose? Are there any conflicts at home that are so difficult that you're causing you a lot of distress? Do you currently have a job? Do you ever feel so much pressure at your job that you just can't take it anymore? Are you worried that someone in your life is trying to hurt you? Do you know anyone who has killed themselves or tried to kill themselves? And what, and this is an important question, what are some of the reasons you would not kill yourself? Remember, we touched on this earlier. Now, you want to make a safety plan with your patient. And creating a safety plan is not a safety contract. Safety contracts are dangerous because they give someone, the individual, a sense of security that's false. We're making a plan. And our plan is our first priority is keeping you safe. Let's work together collaboratively to develop a safety plan for when you are having thoughts of suicide. For example, I'll tell my partner, friend, sibling, parent. I will call 988. I will call you and discuss coping strategies to manage stress. Do you write things down? Sometimes writing things down helps get them out and manage them. If you're not talking to someone, maybe if you take a walk and think through things, any sort of distraction or self-care that you can put into place. And discuss removing lethal means by saying research has shown that limiting access to dangerous objects saves lives. How will you secure or remove these potentially dangerous items from your home? And ask safety questions. Do you think you need help to keep yourself safe? And recognize here that a no response does not indicate that the patient is indeed safe or going to be safe, but a yes here is a reason to act immediately to ensure their safety. After completing your assessment, you want to choose the appropriate disposition from below. And if possible, check up with your client within 48 hours. So is it that your client is at high risk and in need of an emergency psychiatric evaluation? Is it more that there's further evaluation of risk if necessary? You might review your safety plan and send home with a mental health referral, hopefully within 72 hours. You might benefit from a non-urgent mental health follow-up post-discharge, so within 30 days, again, reviewing the safety plan, or you may determine that there is no intervention necessary at this time. But for all positive screens, you want to follow up with the patient at their next appointment and do this same exercise, and you want to provide the resources to your patients, 988, or you can text home to 741-741. So in addition to 988, there is a crisis text line. Text the word home to 741-741. So in terms of our response plan, we have a semi-structured interview of recent suicide ideation and chronic history of suicide attempts. We have then a less structured conversation about recent stressors and current complaints using supportive listening, meaning what I hear you saying is this. We collaboratively identify with them clear signs of a crisis if they're having behavioral, cognitive, or physical issues. We work on self-management skill identification, including things that the patient can do on their own to feel less stressed or distract themselves from these feelings. We collaboratively work with our client to identify a social support network, including friends and family, who many may have helped in the past and who the patient would be comfortable in contacting again in a crisis. We want to review the crisis resources and provide those to them. We want to make certain that we make a referral for follow-up within 72 hours to 30 days. And we want to consider other protective factors that we might unveil rather in talking with our client. And then we want to do additional things in our off time, which is addressing any barriers to care that the patient may have, including the stigma that we're trying to eliminate around this discussion. We want to ensure follow-up visits or contacts are made, and we want to do some sort of risk management tracking of the patient in our chart. So this is also from the DOD, and it is an instruction for their clinicians to recognize the importance of trust between the patient and his or her provider and or care team, and the necessity for the patient to have consistent, open, and respectful communication in the management of their care. We want to provide patients with comprehensive and digestible information regarding the prevention interventions we've discussed and the treatment options that you may uncover, including alternative therapies. For example, the DOD recommends an infusion of ketamine for those that are at high risk of suicide. Our private insurance in the United States is not caught up to this yet, but I expect that it may be coming, and there may be other pharmacogenic and non-pharmacogenic alternative therapies, or therapies rather. We want to use a team approach, including care coordination among other providers, to ensure that our patients are seeing a comprehensive, individualized, and integrated care plan responsive to their goals and needs around prevention of suicide. And then again, we want to embrace family members, caregivers, and support persons in the patient's care and in their safety plan whenever possible. So what to do if someone you know exhibits warning signs of suicide? One, don't leave this person alone. Remove any objects that could be used in a suicide attempt. Call the talk line at 988 and or take the person to the ER. Here are again some more links for you that I thought would be helpful. One is deaths subsequent to discharge from the emergency department or psychiatric inpatient unit. This is around continuity of care. I felt it may be enlightening for some of you. We have a white paper as well for substance abuse treatment as being an element of suicide prevention. We have an LGBT initiative. Given that there is a lack of data in this population, there is the American Foundation for Suicide Prevention LGBT initiative. There is the DOD suicide outreach line that I reviewed. And there is this, which is in my line of work. It takes a community report on the summit on opportunities for mental health promotion and suicide prevention in senior living communities. And remember that those who are over 45, middle-aged adult white men are the highest at risk for suicide, and it would be many of the people living in our communities. I've included a link here for the Ask toolkit, the Ask questions that we looked at earlier, as well as the 6 questions from the Columbia Psychiatry Department. And then the bottom link, the Link Counseling Center, is a link to these and many other links that may have to be helpful. Yes, Ms. Ball, the code is assess. I'll put it into the chat room now. That's the capital A, all lowercase, SSESS. Assess is the password for today. And that is the close of our presentation. Thank you so much for being here. Please join us on Monday. With no irony intended, our Monday session at noon is funeral and end of life planning. Please register for it and join us for that discussion on Monday. I believe it's December 4th is the date. Thank you so much for being here. Again, I'm going to read to you, those who may have come in late, our evaluation link. It is https://www.surveymonkey.com/r/all uppercase letters, V as in Victory, F as in Frank, D as in Dog, Z as in Zoo, H, R, C as in Cat. Thank you so much. Assess is the password, Ms. Williams. That's correct. Thank you all for being here. Please join us Monday. Thank you for all we do. And again, if this was triggering for you in any way, please remember 988.